But what I thought we could start with was just going around and doing brief introductions on yourself, your title, the hospital you're with, and then kind of our first topic we're going to talk with today is what would help your donation program be better? What would help it succeed further? What do you need from LifeCenter? And that'll kind of be our starting point. So is there any volunteer that would like to go first?
I'm happy to start. This is Susan Halver, and I'm the manager of spiritual care at Providence Alaska Medical Center in Anchorage. And just as a heads up, I'm going to have to go off screen because I'll be driving shortly. And as far as what would help us be more successful, I think just continued strengthened collaboration and communication between all the different stakeholders.
I'll go next. I'm Brandy. I'm the manager of surgical services and endoscopy at Benefice Health System. I play the program coordinator role here within our organization. Something really to strengthen our team. We have a very successful program here, but I think the education that we provide for our staff from acute level to more of our ICU ED level that is completed yearly, also with our provider education and engagement with Dr. Suter, I think has been very successful and something that I look forward to continuing.
I can go next. My name is Michelle Didio. I'm a neuroscience clinical nurse specialist at Providence Swedish, but Swedish in Seattle, Washington. And I work in support for the Swedish legacy Swedish system. I think we have done a lot of collaboration with LifeCenter Northwest. Not sure that we have a lot of things that feedback-wise that I would automatically say we need to improve to be able to help improve our program, but I think we're on track with a lot of the things that we're working on, which is a lot of case debrief work. We've been working on our early referral criteria, kind of growing pretty well actually. So.
That's great. And I see Dr. Fagley, you have your hand raised.
Yeah, Elliot Fagley. I'm the Pacific Northwest Division Director for Critical Care for the Virginia Mason Franciscan System. Provide leadership for all 8 of our critical care teams. In terms of things that I think would strengthen our program, each one of our different hospitals has a little bit of a different culture when it comes to organ donation. Some have a quite strong background, and others have shown a little bit more resistance. So, I think just trying to raise the water level for everybody across the whole system and finding a way to get folks all rowing in the same direction.
I'll go next. My name is Rose Atkins. I'm the Director of Inpatient Services at Auburn Medical Center and Covington Medical Center for multi-care system. And we have a strong, long history here of support for donation. The one thing I'd like to see is a little more engagement from our emergency department. They seem to delegate it all to the ICU, whereas there are many, especially with our capacity problems, there are many patients that are held in ICU long enough that they could have been referred, held in ED long enough that they could have been referred while they were down there. Thank you.
A really good one, Russ. Who would like to go next?
I'll go. So I'm Jen Moyes, and I'm a nursing director up here in Bellingham, Washington at Peace Health St. Joseph Medical Center. I'm also the manager of our ICU. And I think things that we do well is we've brought a huge awareness inside of the hospital. So it's not one person being driven for the program. But I think the other components that we're still working on is really creating that level of engagement at the front line and really creating that we own this program and really taking those next steps. And I've got some really exciting things that are starting to happen, and that's very rewarding.
It's great. Well, if you want to share further into that, Jen, we are open ears.
Oh, sure. I didn't want to talk too much.
No, you're fine.
So we recently, we've done a lot of work with our respiratory therapists to help for early extubations, and we had put some particular steps in place as well as education. And so they have a checklist and a process to make sure that they go through before we do any extubations. And I had one of my therapists while I was on PTO this summer who actually drew the line and actually said, wait, stop, as we were getting ready to do an extubation down in our emergency department, because that is probably one of the most vulnerable places that we have, because of the type of patients they care for, and the consistency isn't always there because it usually does show up in the ICU. And it probably wasn't handled the smoothest, but the fact that they had the knowledge to actually question the process and really make sure that all the steps were in place and that we had received the call back from LifeCenter before we did the extubation I looked at it as a huge win, because that was a big step forward with not just being owned by nursing or by our physicians, but being owned by some of the other support services that care for our patients. And so that was a huge win. The other thing that I have that's happening inside of my ICU is I have a couple nurses that really want to continue to refine our processes. And these are frontline nurses who are really looking to say, how do we own this work and make sure that we have a really solid process? And I asked them as they're getting ready to do the work is to really look at both days and nights to make sure that we're not leaving any one shift out of the process. So knowing that my frontline nurses are actually going to really help to solidify some of this work in the ICU is also really exciting. And I said, I'm here to guide you, keep you where you need to be, but I'm super excited to see what they come up with.
That's great. You guys were able to create some ownership in other departments. I think when you start to see that happening across the hospital, you start to see that shift in culture. So it's really neat that you guys have been able to start that. Great. Anyone else want to share with a few more?
This is Kelly. I'm happy to share. Kelly Garth Green, Assistant Administrator at UW Medical Center, and specifically the Montlake campus. And I think what we're doing well is that everybody is really engaged in this work. But what we're not doing well is we've had some extubations without calling or calling just a little bit too late. So we still have some work to do in that area. But we are working on, we have a new checklist for our respiratory therapists, which is helping to engage that piece. And we've recently done some work with our epics. So we're hoping that it's going to improve.
That's great. I like your badge back there. For your badge pull. Anyone else that would like to share?
Hi, this is Teresa Montoya. I'm the Director of Critical Care at St. Joe's. I think what we're doing well is we have a pretty good collaboration with our hospital team and the LifeCenter team. I think where we're really needing to focus is getting some more frontline staff engagement. We've got a lot of new staff, so really getting into them as they're onboarding and helping them understand the systems. But I think what we're doing really well is we are stopping and we are huddling together and having crucial conversations when things are coming up. And I think that's really helping drive us to understand what additional support between our teams we need. So I think we're doing a good job with that.
That's awesome. I'm seeing some good themes across the board with engagement and new staff and making sure it's owned kind of by everyone versus just one unit, which I think everyone probably agrees on, wanting to disperse that across your colleagues. Well, thank you guys for sharing. A lot of you guys brought up topics that are really specifically related to our End the Wait campaign that we've all been working on for 2.5 years now, I think. It sounds about right. If Rachel, if I'm wrong, correct me, but about 2.5 years, you guys have been engaged specifically on that campaign to help reduce the amount of people on the wait list waiting for their life-saving organ. And we're curious what your thoughts are on how that has been going. A lot of you just mentioned projects that are specifically tied to that. Are you feeling like those are going well? Do you want more support in them? Are we missing something within that campaign that you need more support and help on? What have been kind of strengths and challenges with it? We're really looking for any and all feedback you have on our End the Wait campaign.
And I can just add, Mallory, we are going to be continuing it obviously in 2024. We aren't anticipating actually a lot of changes to the overarching goals. We think we are pretty spot on with the eliminating early extubations, as many of you mentioned when you were speaking. Honoring donor decisions, we've seen a lot of progress on that. I would say they're not without challenge doing those cases, and they're not without additional follow-up and additional communication. But I think, as you've all mentioned, we have really strong relationships, which helps us navigating those. And the ones that are challenging, we're doing further follow-up to be able to say, like, how can we make this better? How can we make this process go more smoothly? So we'll continue that work into next year. And then the other one is connecting with families. And what we've been focused on the last year is really identifying that kind of perfect time to speak to the families when they're understanding, but it's not too late. So we're planning to continue to focus on those in the new year. And then we're also starting just trying to be more present in the hospitals and making sure that if we're checking on another referral, that we're checking in with the charge nurse and saying, is there anybody else we could look at right now so you don't have to call us later, or you don't have to wait for us to come back on the unit. So those are things that we're looking at. But I think the question, as Mallory said, is, do those feel like the right spots for you? Are you getting the type of support, or is there anything else that we're missing on those kind of strategic priorities from a LifeCenter side that you would note for us?
I think for us, we touched on it a little bit at one of our End the Waits is just DCD patients moving forward if they are registered, right? That all started early April. So I think it would be good to focus on that within the next year. I don't know how many people have been able to experience that, but we've only really been able to experience that once. And so we don't really have a good foundation of what that looks like, and not a good, foundation to help us navigate through these. Although we have a great policy, it would be good next year to kind of visit on, visiting more of those scenarios and how everybody has navigated those patients.
Thank you, Brandy. Other thoughts?
I think one opportunity that we see a little bit of a pattern with is kind of follow-up in communication. I know with our hospital development coordinator, there's been a lot of communication about, being more on site and rounding a little bit more from LifeCenter within organizations. And I think some of the direction, which we have a great relationship with our coordinator. All of the feedback, we can really address a lot of situations more in real time. But I think the opportunities that get a little bit confusing for staff have been, the need to have standardized communication when they make a referral, when they make a re-referral, they follow back up, make sure that you do, everybody's saying the same thing about what the next steps are from LifeCenter. So knowing that the staff are always changing, you know, and even every 4 hours, maybe a little bit in the care of a patient, but the communication to them about what the next steps are and what we're waiting for are the same.
So really ensuring that there's standardized communication from LifeCenter, and, you know, one person's not saying, oh, we're closing out, and one person saying we're ruling out, and those are two different things, but your staff may not know what that is. I'm just giving an example.
Or like, okay, thanks for calling, we'll follow up, but really what it is do not extubate this patient.
Okay.
We are evaluating whether or not they will be a donor, and if we need to progress to DCD or, you know, things like that. Like, what are the actual legal next steps that are behind the scenes that the staff are like, okay, I made a referral, you know, I don't know what else I missed, you know, that kind of piece.
Yeah, so just clarity of communication. That's really helpful. Thank you. Dr. Fagley?
Michelle,
Oh, go ahead, Mallory.
sorry, I have a follow-up question for Michelle, and then we can jump. But
Okay.
Michelle, do you see a difference in that communication when it's over the phone versus when staff are on site?
I would say we've, you know, we had some challenges with referrals where the on-site organ recovery person was seeing another patient. We made a ton of calls about another patient, and they were like, oh, they're not going to be a candidate. And nobody ever walked over to the other unit to see this patient or to connect. And so we have these like gaps where it feels like on site, but not like around, maybe. So maybe not the full rounding, checking in, those sorts of pieces. That can be kind of a gap that we see.
Thank you.
Mhm.
Sorry, to go ahead, Dr. Fagley.
So, you know, I think one of the things that has worked really well in a number of our hospitals has been the identification of staff nurse champions for organ donation, and not relying quite as heavily on our nursing leaders per se, because our nursing leaders are, you know, they're trying to get, you know, holes filled in schedules, and, you know, trying to recruit staff and those sort of things. So, you know, adding more things to their plates can really be quite challenging. But there are a lot of our nursing, you know, grassroots team members who feel very passionate about this work, and you know, finding a way to you know, for lack of a better word, capitalize on that passion for organ donation, I think really goes a long way. So, you know, I think that would be something that that would be a type of program that I would love to see rolled out across, you know, all of the hospitals in the Pacific Northwest, and, you know, trying to get folks that, you know, feel passionate and can also then help train their own team members, their co-team members, et cetera.
I think that's a great idea. I'm sort of envisioning we have obviously our in the wait site champion things that we're doing, but almost kind of pulling that through to the frontline nursing staff that really want to champion that day to day, and maybe doing smaller programmatic things within the hospitals individually for those team members. That's great. What else comes to mind? So one of the things that we're also looking at LifeCenter is making our teams into smaller regional teams, so that there would be consistent staffing, so that the coordinators that come to your hospitals are probably like 3 to 5 people versus one of 20 that you could get on a given day. We've attempted this in the past at LifeCenter, but what we've discovered in the last bit with our research is we think our regions were too big. We would have, you know, various regions throughout the 4 state areas, but particularly in Western Washington, we just had divided like North Sound and South Sound, but that is way too big of a region. So we're looking at smaller regional areas like Central Seattle, Renton, North Tacoma, Olympia, those kind of things. So we're really trying to move that direction to ensure a more consistent staff. And based on that, we've actually approved quite a few additional hires to ensure that we have the clinical staff that's needed. Because when we've attempted it in the past, we've always ended up having to pull the staff to go elsewhere because we can't really predict where the donors are going to be on a given day. But so that's one thing. And I'm curious, I see heads nodding that would be welcomed, but I'd be curious, any thoughts or comments about that particular strategy?
Hi, this is Teresa Montoya again. Yeah, I think it's a great idea. I think part of, I was really kind of resonating with Michelle as she was talking about the on-site versus, there just sometimes is a little bit of disconnect on terms of what is the plan. And when you have multiple cases going on, I can totally see how that would get a little muddy, I guess. But then when you have different people that come to your site each time and they may only be there, it is their 1 in 20th time being there. I think any consistency that we can provide around this is only going to benefit how we standardize our work. So I think it's a great opportunity, and I hope you guys are able to move forward with it.
Thank you. But that's what we've heard from multiple people. So we're really working hard to operationalize it. Like I said, I believe they approved 20 additional staff so that we could actually make it happen. And they are in the process of hiring it with the goal of having all of them hired by the end of the year, because we really want to be able to put this into place. Our challenge now, is I'm sure all of you as leaders can appreciate, is the training. How do we get them all trained and up and running in a pretty short time? But we're working on that as well.
Yeah, I think the recognition, the familiarity, the relationships, being able to have a relationship, recognize people, that will be huge. That'll be huge.
Well, kind of on that same note, Rachel, would you mind sharing a little bit about our strategic plan for next year and anything we haven't already chatted about, inclusive of that, and getting some feedback on that as well?
Yes. So a lot of the things that I've mentioned are already on it. We are going to work on trying to we're calling it donation rounding, which is really when we're already in the hospital for another reason, either responding to a referral or the hospital development representative there doing an in-service, just checking in with the charge on the ICUs and seeing if there's anybody that we can refer for you, or if you want to make the referral, then we're available to actually do some of that real-time assessment without waiting. So that's one thing. The regional model that I just mentioned, that is kind of a heavy lift on our strategic plan next year of making sure that we have adequate staffing to ensure that we have timely response. Our goal is really to ensure that we are responding in a very timely manner, regardless of where you are in our region. We cover 4 states, so it's not always easy. And we also think that there's kind of been a shift after COVID of, during COVID, we got used to responding via phone call and not necessarily coming in the middle of the night or coming to the hospital at various times. So we're really trying to get away from that and ensure that we're staffing so that if you call us at midnight and you need us there, like, we're there. And we think that regional staffing model will really help that. The other thing that we're looking at is our potential. So our organ potential has grown year over year, and last year was the first year that it stayed stagnant. So we're really looking at how are we evaluating patients? How are we moving forward on things? Just in the last week, we moved forward on a case of an over 50 patient who had HIV and Hep C, and we were able to place an organ, which in the past that might have been a rule out. And I think all of you know the changes in CMS for OPOs, and our measurement year is next year. So we're really looking at potential. We want to make sure that we are not missing any patient that might have potential, and that we're either talking to that family or honoring those donor decisions. So that's really important. The other thing that we're doing is really building relationships up and down the West Coast, and to like Nevada and Utah, those kind of places with transplant centers. That case that I just mentioned we were able to place that organ because we had gone and visited those transplant centers. It was on the West Coast in California, one of the centers there. And we knew those physicians, we knew that center, and we knew that they had the type of patients that would benefit from that organ. So really making sure that we have those strong communication channels to ensure that we have outlets for those patients. And there's a handful of other things that we're doing on the utilization side. There's a lot of new technology on utilization in terms of looking at different perfusion devices that can actually allow for heart and lungs to regularly be recovered on DCD. So we know some of our transplant centers are looking at using those type of devices. And so we are, just making sure we have the processes in place. I would say that's something that's probably will be reaching out to all of you all in the coming months, I would say, not too distant future, around just these perfusion devices and any questions that we might have in the OR or need to have prepared in order to ensure that those recoveries go as we would expect them. It's all very exciting, really, because a lot of patients are getting transplanted. We're also seeing this year more lives saved than we've ever seen before. In July, we had 42 organ donors and 143 organs recovered, which I think this time last year, we probably at LifeCenter didn't even think that was a possibility. And it happened, and it will likely happen again and with more regularity as we move in to the coming year. So I would say another thing that we've changed at LifeCenter with our new CEO having come from Virginia Mason, very much into Kaizen events and rapid process improvement. And so we're working really quickly to move forward with things that previously probably would have taken much longer. So it seems to be working. So we're going to keep doing it. So that's kind of a summary of what we're looking at for next year. Not really changing course because a lot of what we're doing is working, and some of it I think just needs time to continue to settle. Like Brandy mentioned, the honoring donor decisions. I think many of you mentioned the early extubations. Those things take time, and each hospital is like a big ship. They kind of take a while to turn. So we're just relying on all of you to help us work on those. But I'd welcome any questions you all have about sort of our direction or just anything that you're experiencing with LifeCenter. Thanks, Jen. Appreciate you being here. So it sounds like we're on the right track, hearing none of no detractors or anything like that. Mallory, did you have other? We really just wanted to get feedback from you all to hear that. Are we on the right track? Are there other things that we should tweak? And that's how we see this advisory group of, gathering those ideas that you've all mentioned, and then making sure that as we're moving forward within the weight that we're, following the path that you all see as successful in your facilities. I don't know, Mallory, if you had other things that we were going to talk about.
Just if there's anything we're missing, if there's something that's should be right.
I guess I would add a little bit more about IDCs. So I didn't really talk much about that, but we are continuing to see a lot of success and good authorization rates with our initial donation consults, and that's that earlier connections with families. And I think you all know, but those are not necessary. We don't necessarily always bring up donation. I was actually reviewing one this morning where we did not. We got in the room, we figured it was very clear the family was not understanding. They were not trusting what was going on. They were hoping for a miracle, and we said, thank you, and just politely left the room. We did not bring up donation. So really, we're seeing good success with that. We think that's really contributing to a lower number of registry oppositions on DCDs because the families are able to plan for that a bit. The other thing that I would say that I didn't mention that we'll be focusing on in the next year is our non-registered, both brain dead and DCD authorization rate. And those are not as high as we would like them, and actually not as high as we would expect them, because most of the time there's kind of a general number of people that would say yes. So we believe that there's some improvement that we could have on our family support side, just with some additional training about how to support those families and really make sure they feel heard and understood, because we know when a family feels heard and understood, they're much more likely to offer that generous gift of organ donation. So those are kind of other things that are on our radar, but you will hear more about IDCs. And we think they've been being successful. I am curious if you all have heard any feedback from your teams around initial donation consults or anything positive or negative with the new timing of our connection with families.
I wouldn't necessarily say that I've heard any specifics. We have had some situations where like the families are absolutely dead against waiting one more minute. There's a lot of mistrust in things have happened, and it has felt like there's not really good understanding when we've worked with LifeCenter in some of those circumstances where you're like, this was a really difficult family to broach anything with. Like they were not just oppositional, but angry, or there was just a lot of discord there. And I do think that there's opportunity in us being able to say, like, there are the rules and we're trying to stay within those guidelines, but there are times when we're, the primary team does have a really good sense of what's happening in those rooms, and that opposition isn't going to change. So I think there's opportunity for us to have a little bit more communication and collaboration in those spaces. Sometimes it does come off feeling a little bit like it's punitive and we're in trouble, but the reality is that wasn't the situation. So I think that there's opportunity with those earlier ones to be communicating a bit more with the primary team. And that isn't always nursing, right? Like that is the actual provider teams as well. So I do think there's opportunity in that area. And I do think the earlier communication is going to help with that.
So are you primarily seeing this are you thinking registered donors is where this has come up with opposition, or just any conversation in general?
It's been a couple of different ones. One specific one was with a non-documented patient, and that was super complex.
Yeah.
And then the other one, to be honest, I can't remember the other one, whether or not it was actually, I don't think they were registered.
Okay, so you're seeing an opportunity for maybe more communication, particularly with the provider team around those IDCs and just conversations in general. Great. Okay. Thank you, Kelly. That's helpful. Has anybody else had experiences with the earlier conversations, good or bad, or heard from their teams about earlier conversations, good or bad?
I would say for us, they have been, and I think it's kind of a sign of a good sign is that it's like no opinion either way. It's really a little bit more fact of, oh, they were here to do that IDC, or they met with that family early, which I think I appreciate, because it takes a little bit of the stress out of it. So it was, I think it's a good sign that it really was more of just a factual conversation rather than a lot of opinion about it at all, honestly.
Yeah, sometimes no news is good news, right?
Yeah, that's how it feels. Like, yeah, they're happening. Yeah, that was, they did. They were in there.
Great, thank you, Michelle.
That's good,
That's helpful. Yeah, I think we are continuing to just try to hone that process. We've actually been working on kind of just a little half-page real-time education piece around what is an IDC, because it's truly changing a process that we've had in place for over 2 decades of very strong separation. The family must have made this decision, or they need to have had brain death testing or something. So it's really kind of changing a process that's been in place for most of our healthcare teams for their entire career, I'm sure. So we're definitely cognizant of that and trying to be more collaborative as much as we can. And even though we've been doing it now for a year, that's still a very relatively short time, given how long many of our team members have been working in this space. So thank you for that. Anything more, Mallory? Oh, I see.
I think just if there's anything we're missing, if there's things that you can see that you haven't thought of or things that you know of that would be helpful, we're really looking to you guys for that advice and advisement, if you will. So if there's things that we can start working on or providing or collaborating with, considering for our strategic plan, we would love to hear them from you. Or we can go with the no news is good news too. That's all right.
Well, I think the other thing I would ask, so really this advisor group was for this kind of discussion. We kind of want to run things by you, make sure that we're on track as we're putting together the site champion roundtables and then the content education and sort of strategies for each of the hospitals. So this was very helpful for us. We also want it to be a useful a good use of your time. So if there's anything in this meeting that if you would like to see data or you would like to see, different pieces of information, we would also welcome that feedback.
I think it would be great opportunity as you kind of regionalize like and operationalize the development, the growth of your team, that it'd be great to have them meet with us and our hospital development coordinator so we could be a little bit more on a regular communication process with those on site. So we are a little bit more, everybody recognizes each other and we are a little bit more of a team. And maybe, if there's 5 in Seattle Central or 6 or whoever, they don't all have to be there, but on a more of a standard process that we do all meet together monthly would be great, as close as we can.
That's a great suggestion. Thank you.
It might also be nice to have like a meet your team sort of document, like here are the LifeCenter team members that will be serving your facility, a little picture, a little bio, just something so we can try to make some connection. Because I know periodically one of the things that comes up is, oftentimes these have been challenging situations with families over a protracted period of time. So we as the primary team often feel a real sense of ownership with the family and with the patient, and making that transition and relinquishing that ownership can be tough when you're handing over the care of somebody that you've worked really hard with to a stranger, or somebody who feels like a stranger. So if there's anything that we can do to kind of make it feel less like we're strangers, I think that would actually be really useful.
I love that suggestion. Yeah.
Took me about 15 minutes to figure out how to put that into the words that I was looking for.
Well, we appreciate it.
I do think that that rounding is going to be key. Because, you know, I'm sure I'm not alone in saying that our environments are, it's ever changing, right? Because we, having gone through the pandemic, large volumes of travelers, large volumes of staff moving in and out of our systems in 13-week contracts. So moving the dial on anything is really tricky when you're, you know, a quarter of your staff are turning over in 13-week contracts in some of our ICUs. That's improving, but as it's improving, they're being replaced with brand new nurses or new to specialty, even some experienced nurses. They're still new to our environment. So having that, their rounding kind of helps keep that front and center of all those new spaces all the time.
Thanks, Kelly.
I would just add to that, we're also seeing lots of new leaders and longtime leaders departing. So that would also help rounding wise.
Yeah, rounding, we're really trying to think, how can we provide it, make your life easier, right? How do we make it simpler to do the thing that we know, you know, the nurses want to do or the healthcare teams want to do, but things get busy. And so we're trying to think of those ways that we can make it a little bit easier and less challenging or cumbersome.
Great. Did you have any last thoughts, Rachel or Stephanie, or anyone from the group that you want to share? This was lots of really good discussion and feedback and thoughts and ideas, and I've been furiously taking notes the whole time so we can kind of organize this and get it back out to all of you as well, which I will hopefully do this week. We will be reaching out to figure out a time for our Q4 meeting, but kind of as we're moving forward with some of these ideas, maybe reaching out to you guys individually or as a group for thoughts and feedback in between, just because we are moving so quickly, hiring that many staff and trying to get them trained and up and running for next year. So in the event that we do have to touch base before our technical Q4 time, please know we'll reach out via email. And otherwise, your meeting invite will likely come from Stephanie or Rachel, so I will be out starting this Friday. But I'll be sure to get you all of your information and hopefully the recording by the end of the week. Thank you. It was really great to see you guys and to see your faces and for all the conversation. We really appreciate and value your time with us. So thank you.
Thank you.